Good morning, my dear student. Today we are going to talk one of the very important topic, that is rheumatoid arthritis, which is a very disabling condition, and it's suffering to the mankind. Those suffer, their life is miserable, and quality of life is also deteriorates. Simultaneously, the longevity is also curtailed down. So morbidity is always associated. So necessarily, our endeavor always should be on to help this category of person with rheumatoid arthritis. So we are going to talk on the definition, epidemiology, pathophysiology, clinical features, diagnosis, treatment, and also physiological importance. That means extra pharmaceutical treatment also very important. So by definition, you all know it is a chronic disabling disorder, chronic inflammatory systemic autoimmune disease characterized by destruction and proliferative changes in the joints, as well as extra-articular part also. This extra-articular part we talk system that includes sometimes lung, heart, nerve, liver, so many things. So joints usually is destroyed, leading to deformity, various deformities. And finally, it may go for ankylosis because the articular cartilage is destroyed. Associated with extra-articular manifestation, certain organs are affected, mostly, not all. We'll talk about it. So if you look at the epidemiology, it is seen that almost 1% of the people are suffering from it. Roughly 1%, mostly in case of female, and it is seen 30 to 40 years of females are more predominantly involved. So it is the 30 to 40 years of female more commonly involved in the epidemiology. Then certain things are there. Pima Indians means the indigenous people in America who are more sufferer. So certain, as you know, that we actually do not know the cause, truth. But there are certain factors which plays. What are these? It is a genetic environment where certain genetic things are there. Then associated with the environmental factor and an infective environment, infective condition. So these are the three contributors to start this disease. So what are the predisposing factors? Genetically, this is the ACLA region class 2 genes. ACLA DRB4 positive patients develop more erosion, and 1/3 of the patients have ACLA DRB4 positive. So that means genetically predisposed persons in a favorable environment may end up into rheumatoid arthritis. In other words, though we do not know the cause, so we blame that a person who is genetically designed like this and an environment which also contributes. It is said that smoking is another triggering factor to it. Then certain infective conditions may be blamed also. That is mostly the virus. It is said chikungunya by Epstein-Barr virus. Are you getting my point? So these are the three all platforms. They ultimately contribute this autoimmune disease. That is how it is coming up. But yet to pinpoint who is actually responsible to do so. So in the course of treatment, in the course of your disease, predominantly patient used to come to us because of this involvement of the joints. It is true, there is extra-articular involvement also. But extra-articular manifestations are usually late. Most of the patients come for treatment for the involvement of the joint because it affects the mobility of the person. So it affects the day-to-day activities of the person. That is why they used to come most of the time. And most of the joints here, symmetrical small joint involvement of the both upper limb and lower limbs are the main. But it is also true that sometimes monoarticular involvement, single joint involvement is also seen in case of rheumatoid arthritis. So by and large, mostly small distal involvement of the symmetrical involvement of the joints are mostly seen. Interesting point you must remember, a DIP joint is not involved. So in the hand also the PIP and MP joints are commonly involved. But DIP is escape. Joints that typically is paired in distal is an interesting point. If you remember thoracic lumbar joint, SI joint, though they are synovial joint, but they are escaping from here. So sometimes we have a question that what are the joints escape? Though they are synovial, but they escape from the effect. So as I said, extra-articular manifestations are also seen. This includes what? The heart, most of them pericarditis. Other things are there, but pericarditis is more common. Liver, it is said is Jongren syndrome. Then in blood disease, most of them anemia. Hypochromic, anemia is quite common because of the disabling chronic disease. Eyes are involvement, keratoconjunctivitis is more common than other things. Then in the pleuritis, it is pleuritis. Pleuritis and pleural effusions is sometimes seen. Pulmonary nodule, then Kaplan syndrome, other things are there, but pleural effusion is quite common. Symmetrical bilateral involvement of the pleural effusion seen. So in the periphery, in the skin, also rheumatoid nodules are seen. And one thing is that presence of rheumatoid nodules is not a good sign. Certain prognostic factors are there, one prognosis, that certain patients respond well to treatment, but certain patients do not respond well to similar treatment. And one of the reasons is seen that those patients who is having nodules are poor responder to treatment. Now try to understand the pathophysiology. The rheumatoid arthritis, the immune system is somehow is wrong. Some information is wrong. Some information is wrong in the immune mechanism. The attack, that is why it starts attacking the. How this happening, we'll talk. These are the symptoms which have been pain, inflammation. That because synovitis is there, later on there is cartilage destructions, simultaneously tendon also involved, and joint eventually loses. This is actually cascade of clinical events. But what happens inside is autoimmune. This is the factor. So this is because the whole things happen because of the autoimmunity. So defined as the failure of the organism to recognize its own constituent part, something wrong. Body is developing antibody against its own structure. That is the main reason. Why this happening? So it is not very clear here. So which allows the immune response against its own tissue. Any disease that results from such a aberrant immune response termed autoimmune. As you know, autoimmune means a disease where the antibody is formed against its own organ or agent. So that is the main important thing. Why it happens so, we don't know. But there is various cascades of events. There another discussion we'll talk about this, how it happens, what is the gate system, how a controlling mechanism is lost. Autoimmune, this sort of your autoimmune process is not unusual, but there is a controlling system also to control from periphery, from the central. The control system is failed. That is why there is autoimmunity is taking place. That means autoimmunity is not an unusual thing happening in your body. But inside the body, there is another mechanism which controls it. This control mechanism is in peripheral and central. Now, wrong thing is that sometimes this controlling mechanism fails. And this failure of controlling mechanism helps in propagation of your autoimmunity. That is it. We'll talk about this thing again in details. How this controlling mechanism works. There is controlling for the beta, T lymphocyte and B lymphocyte, which are again peripheral and central. Now somehow this controlling gate system, controlling to not to go for the autoimmunity, because sometimes autoimmunity produces inside the body. But the control mechanism is there to control this so that there is no progressions of this autoimmunity. So this controlling mechanism is failed here. So that is why autoimmunity takes place. That autoimmunity is called peripheral or central autoimmunity. That is another thing we're going to talk. So now, if you sum up these methods in a genetically designed person, in a favorable environment where infective factors may also be responsible, induces pro-inflammatory cytokine. Ultimately, whatever the cascade of events of destruction is taking place because of the proliferations of the cytokines, which mostly include interleukin 6, interleukin 1. There alpha and beta, some classifications are there. Now these cytokines, what they used to do, they actually stimulate or propagate, give impulse. Cytokines are basically peptides. They are a messenger between the cells actually. Cytokines are basically a type of peptides, a messenger. They give message to what? To the macrophage or to the monocyte that you go to the inflammatory one. Because it is basically what? It is not the cytokine, it is the proliferation of the cellular tissue, inflammatory cell. Because in the synovium, what do you see? We see accumulation or aggregation of the cell. Yes or no? Hyperplasia, reaction, whatever it may be taking place, synovitis is the what? That is means accumulation of this inflammatory cell there. Why this inflammatory cell is coming to the synovium to attack? Because they are getting an impulse signal from where? From these peptides. What is peptide? This is the interleukin interleukin. So cytokines are the messenger. They used to stimulate the monocyte and macrophages to come to the site of action. What is the site? Mostly the synovium. So they accumulated, then cellular proliferation, say inflammatory reactions are taking place. So this is because of these cytokines. Yes, understood point? So it contributes to PANAS formation. Ultimately, while there is aggregations of the cell, there is a formation of the PANAS. At the junction, at the periphery of the joint many times, then they propagate towards inside the joint and they call the erosion of the joint. So these things are happening mechanically there. But this is happening because they are getting a signal from the peptides. These peptides are mostly interleukin or interleukin. They are sending impulse to the monocyte and macrophage to go there, accumulate there, attack there. So they are attacking. So they are getting a signal, that is why they are attacking. And this attacking leads to your formation of PANAS and then leads to your erosions of the other things are happening. So erosion taking place, then subsequently clinical features are coming out. So this is actually happened. So you should understand how the process starts. So in a healthy environment, it is okay, fine. A healthy joint, you all know. So in a arthritic joint, so all the cells are coming up. These are the cell, plasma cell, or whatever, leukocyte, the macrophage, osteola. So many action is taking place in this area. Why? Because they got impulse stimulus from where? From the cytokines, from the peptides. They told, they go there and attack. So this is where they are coming. So they are coming because they are getting information. So that is why all the things are happening there. But whatever may be, the destructive features taking place here, and subsequently, because of this destruction, we get the clinical features like this. So this point should be clear, how it happens. So normal joint, rheumatoid arthritis joint, you all know what is the PANAS formation is the most important thing. Then this PANAS ultimately erodes the joint by causing destructions of the articular cartilage. And you all know that once the articular cartilage is destroyed, it destroyed forever. So there is no repair. It may be repaired by it may be fibrocartilage, not similar to that of the hyaline cartilage. So there may be repairment, but the repairment is not good, because you all know the articular cartilage are a special type of your cartilage cell, where reparative mechanism is somehow is not similar to that of the other tissues like the liver or the bone and everything. So reparative mechanism is not good. There may be replacement, but it is always fibrocartilage, not the same with the original articular cartilage, hyaline cartilage. So that is the thing. So that is why it progresses like this. So the stages are there. We are not going to talk about this because more the destruction. More the prolongation, more is the destruction. So that is quite simple and happens if you do not interfering it early. So this leads to since it is a chronic disabling disorders, if it happening whole throughout the body, that is why some clinical features, generalized symptoms are always there with the fatigueness, with the joint pain, as you know, the characteristic joint pains and stiffness is supposed to know. Morning stiffness extending up to more than 30 minutes. These are very important things. And tenderness, simultaneous swelling also. So many things are here. And characteristic joint stiffness, you're supposed to know in the case of rheumatoid arthritis how it is. So in the morning time, while getting out of the bed, patient used to complain that I do have difficulty in doing this movement here because the joints are involved. Some swellings are here, which is persisting more than 30 minutes. Is a very good information from the clinical point of view. If it is happening simultaneously in the lower limb also, small joints, and an upper limb, that is another good sign. So in the female, 40 years, come to you with a history of morning stiffness of the fingers and the small joints in the foot, sustaining it more than 30 minutes, get relief after some time, and the daytime she is relatively free from the pain, is a very good clinical information of rheumatoid. It's very important. The history taking is also important. So this is the thing which should come to your mind. So these things are always there. But if it is coming late, while you do the X-ray and everything, destruction is there, this is already gone case. So your endeavor always is there to extract the information as early as possible, intervene in early. That is the basic treatment protocol and aim in rheumatoid arthritis that you try to prevent further damage to the joint. But once there is damage, it is permanent. So these things are there, anemia because of this, as I already told, other systems are involved. So he is anemia, loss of weight, then also other problem will be there, sometimes mild fever. These are there. But in the long run, we get various types of deformities involved in the joint. So it may be swan neck deformity, buttonhole deformity, mallet finger, jet deformity. So many things are there. Ultimately, this all consequence because of this destruction inside the joint taking place and the deforming force working it leads to your some sort of deformity. Force working on it leads to your deformity like this. So these deformities, as you all know, these are very important thing. You should know from clinical point of view. Now, certain these are the deformities we know. You have to know it, and we are not going to talk about this. So some poor prognostic factor. Now these certain groups of patients. Now we are, as I said, our approach in these situations or rheumatoid arthritis that we try to diagnose him as early as possible with the help of the proper clinical examination and also laboratory finding. We are going to talk on what basis we are going to diagnose this patient. ACR guideline, we talk. But certain things are also important in the prognosis later part. You follow up the patient. The certain patients are going to respond well, but certain patients are not good responder. Certain things which also determine this, you can make out that this person is not going to respond nicely. But this group of person is going to. Certain females are not a good responder. Cutaneous lesions, if it is present, it is not a good sign. So poor functional status, involvement of multiple joints, then early radiographic evidence that erosion is taking place already, the patient is coming late. And if there is radiological finding positive already, this is not a good case. The advanced age and onset disease and high RS titer, I will talk this titer, the important, if it is high, this is not a very good sign in prognostic point of view. So prognostic point of view, these are things we should keep in mind that you can know that this group of patients may not respond to the desired treatment by the desired treatment. These things, as I told you, smoking also contributes to this thing. So how we are going to diagnose this patient? How we are going to diagnose this patient? The history taking and these things are important. The classical features, as I said, the morning stiffness sustaining for more than 30 minutes. In daytime, she is better. Again, it is coming up in the evening time. This is proper history. So positive physical examination like swelling, functional limitation, deformities, if there is already advanced case, easy to diagnose. So we need to go for certain blood tests, which includes ESR, CRP, associatedly there is anemia and rheumatoid factor. Then other things are coming up like NDCCP and other things are also there. So this helps you to come to a diagnosis in this situation. So rheumatoid factor is an antibody reactive Fc fragment of the IgG. IgG is produced. IgG is produced. This down against this IgG, Fc fragment, it has a light chain and then a heavy chain. And this RH factor is nothing but the antibody is produced against the Fc fragment of the immunoglobulin, IgG. So antibody to cyclase is NDCCP. NDCCP has higher diagnostic specificity in rheumatoid. And one thing I like to tell you, the RH factor is present in positive cases up to 75%. 25% do not show positivity. On the other hand, positive RH factor also does not say that it is a case of rheumatoid arthritis. Two things are there. I am talking two things. All the rheumatoid arthritis cases do not show positivity of the rheumatoid factor. Only 75% show it. 25% does not show it. On the other hand, positive rheumatoid factor also does not tell you that this is a case of rheumatoid arthritis. Certain other conditions where this may be positive. So you have to be, it is not a very specific, though it is giving a signal that it's a case of rheumatoid arthritis. Yes, so you have to sum up this matter with the other evidence as well. Antibody, NDCCP is also important. The diagnostic specificity is high. It is more specific than that of your rheumatoid factor. So X-ray, as I said, early sign is revealed the swellings of soft tissue. Joint erosion, osteoporosis sometimes. So there is soft tissue swelling with your osteoporosis adjacent to the joint. These are early signs. But in late cases, you are going to erosion, reduction of joint spaces, and associated deformity are the late features. Early features are osteoporosis and also small swelling of the joint. So these are the current ACR guideline. ACR guideline, go out. ACR guideline in there, then you have to know this thing. Large joint, 0. 2 to 10, large joint, 1 mark. So these marks are important. Marks are important. That how you have to calculate this. The ACR guideline is the guideline which is internationally accepted for diagnosis of the rheumatoid arthritis case. So if the oligotype, 2 to 10 large joint involvement, score 1. 1 to small joints is involved, it is score 2. 4 to 10 small joints, scoring is 3, and more than 10, 5. So it is more important given to the symmetrical involvement of the small joints. So though, as I said, monoarticular big joints are also involved, but the scoring is, that means this is less. Some other causes may cause the monoarticulopathy. But the poly small joint involvements is more indicative of rheumatoid arthritis than mono big. Are you understand? Do you understand the point? That supposing knee joint is involved. Yes, there is a possibility that monoarticular knee joint may be involved, elbow joint may be involved, single. But if there is small joint involved, symmetrical, both upper limb and lower limb, these give more weightage than that of your head in clinical diagnosis. These are the factors you have to remember. So serological point, there is a negative RH factor, negative NDCCP. So lower positive RH factor, lower positive NDCCP 2 part. So high and high, both high is a 3 mark. So if this scoring is 6 out of 10, so it is case of rheumatoid arthritis. So history taking is very important. You have to remember this thing. And as you know, that you have to diagnose the patient early before radiological findings are positive. If the radiological findings are positive, that means a late case and your results are not good. Results are not good. So that is why one should always give sincere effort to diagnose the patient as early as possible so that we can give a better result. So it is true that today we do not have any medicine or anything which can eradicate this disease. This is not possible. Like tuberculosis, you can do it, but here it is not possible. So here one can give remission to the disease, and also you can reduce the disease activity. So one can do remission is sustained, but it's not yet over. Remission may be there, like getting relief of this problem, but not exactly eradicated. Or there is a low, so that means if there is more animal, more fatigueness, more problem, more, at least you are assisting him by giving medicine so that his disease activity is somehow lower. So if it is remission is good, if not possible, at least to reduce the disease activity so that he can have a better quality of life. But eradication as such is not possible with the armamentarium available with us. So that is why the principle of treatment is to do early diagnosis and early treatment. Treat to target is a new concept coming up. We are going to talk. And a combined medication to achieve remission. That means if monotherapy is not working, then you necessarily go for combination. But today's picture is a bit different. The earlier date we used to go for what? This is a pyramid. That means you are additive. The today's concept of treatment in rheumatoid is reverse. We are going reversing. Means what? You are going to multi-pronged treatment. You are going to attack the disease from the both way, all the way. Reduce the disease activity and maintain it. Earlier days, the concept is you are getting analgesic, not responding, then the DMRD, or not responding, then go for biologics, something like that. You add up. Or if you do methotrexate is given alone, then again you add something like this. But today's concept is just reverse. You try to reduce the disease activity by giving multi-pronged treatment so that if remission is taking place or lower disease activity is there, then maintaining with a lower dose. This is a reverse. So not a step-ladder pattern, but a reverse pyramid type. So symptoms of treatment. So the armamentarium with us by which we can deal with situations like analgesics. But simple analgesics, what? It is going to painkiller sort of thing. Means the ultimate destruction which is happening there is there, you are reducing the effect, but not essentially affecting the process which is going on. Yes? So we are giving the treatment so that he can get relief of the pain. But what is going on inside is not intervened. That is minus point with the non-steroidal anti-inflammatory drug. There, which may be again better by the COX-2 inhibitor or whatever it might be. Then you can add analgesic to it. Okay, fine. You can give analgesic so that they can get a better quality of life. But it cannot actually intervene the process which is going on. So DMRD is this choice. So in today's picture, today's situation throughout the world, start the DMRD as early as possible. So these disease modifying agents which reduces the symptoms and progression of rheumatoid arthritis as well as improve the quality of life of the person. Minus point is that it works very late. So many times you have to wait for 2 to 3 months time to get efficient clinical improvement of the person. So in this type where the methotrexate groups of drugs or DMRD is slow responder, slow to give the result, you can continue this period with a bridge therapy concept, the corticosteroid. So corticosteroid can be added, or sometimes even analgesic also can be added, so that patient gets relief by the time the method DMRD actually shows its effectivity. So that is why bridge therapy, this is called bridge therapy with the corticosteroid. You should understand what is called bridge therapy. So sometimes, of course, remember bridge therapy also, beside bridge therapy, corticosteroid can be added in a flare-up case, which is flare-up, acute onset. There one can give Solimental infusion also. And again, you will find the person is responding well, but one or two joint is not responding. There you can give intra-articular injection with steroid also. So steroid has got three types of more. One is acute flare where you have systemic IV steroid to reduce it. Then again as a beach therapy, or again intra-articular injection in a case where many joints are controlled, but one or two joints are not responding. One can give intra-articular steroid there to get this effectively. Understood? So these are the steroid protocol. So DMRD all know methotrexate, leflunomide, sulfasalazine, hydroxychloroquine, azithromycin, so many drugs are there. But out of this, methotrexate considered to be best one, which can be given parenteral or orally or injectable. Usually given subcutaneously, it is better. It said if it is absorption is somehow is questionable. So it is better to get IV, but it is said in normal situations, IV, whether you give it subcutaneously or orally, almost same result. Yes, so many a time people used to give it injectable and subsequently continue the oral therapy. Minimum 50 milligram to 30 milligram weekly dose. Yes, that is very important. So if the patient confuses and take it every day, there will be severe depressions. We have seen patients mistakenly they are continuing the methotrexate every day, and they severe depression is involved. So next drugs available with us is the biologics. Nowadays biologics plays a very important role. So these are the biologics which are coming up nowadays. Biology basically are what? They are antagonists to the your interleukin or the peptides, as I said. So are doing antagonistic activity. They are antagonistic. So that is why the subsequent macrophage and other things are not coming up. As I said, peptides are the messenger sort of thing. So the biologics work at this messenger level. So that the subsequent chemotactic activities and other activities are curtailed now. That it is well. So you do have so many types of biologics. The biology work here, but there is a minus point also. That is the case. Peptides are important for us for defense mechanism as well. So thereby it can help proliferating or stimulate some other disease which are in dormant stage, like tuberculosis and other things are important. So these are important to be controlled if there is in your body also. So peptides helps us to control because of it stimulates these macrophages and other things to go there and control it. In a situation where pen control is there, pen control, because you control everything, so the others may take the advantage. That is minus point. So you have to analyze the patient before starting the biologics, that he is not suffering from tuberculosis and other things to be excluded. So these are the drugs available nowadays. But one thing I might is a biosimilars. What is this? Biologics are very costly. Original. Nowadays, pharmaceutical companies are producing similar product in synthesis, which is similar, almost similar, but the structure is not exactly similar to that of the biosimilars. So you may find that people are coming with very easily available antiseptic or oral preparation something. It is true. These are called biosimilars. So biosimilars almost similar to that of your biologics, but actually not same. So they are produced synthetically. Have you get my point? So they claim that initially original biologics are given, then you can switch over to the biosimilars one to have this sentence. But many times it may not reflect the same. But biosimilars are coming up. Easy thing is that biosimilars is less costly and easily can be given. Yes, that is like the actual biologics. Understood my point? So these are called biosimilars. So you may get the biosimilars available today, can be given, and claim that you start the biologics, then switch over to biosimilars, which are less costly and easy to give. That is the thing. So one should understand what is biosimilars and what is called biologics. So this is the history that biologics 1998, atrasentan, infliximab, so many things are. This is the 2001. Anakinra is mostly used in case of children. Yeah, juvenile hepatitis, very important drug for them, which are not responder. So these are the things available nowadays. But now what we are stressing is called JAK inhibitor. Biologics are there. I told you that where biologics X and you have so many biologics available, there is a protocol of treatment also. You need to hospitalize the patient, assess the patient on having tuberculosis and other thing, then start with a specific interval dose. Okay, that is one. That can be switched over to biosimilars later on if you feel like and you are confident enough. But another thing is now called JAK inhibitor. What is this? We are going to talk about this JAK inhibitor now. So factors affecting drug choice, that means you have to select it is tailor-made. Not you have to select the patient and accordingly you have to start the treatment which is going to work. Many times it is your DMRD which is first line of treatment. It is true. If the DMRD is not responding, people used to switch over to biologics. Then after biologics, one can continue as a biosimilars. That is protocol. That is mostly practice, but may not be possible in only cases. And as I said, even doing so, 30% of the patients do not respond to it. Almost 30%. These 30% patients can be treated now with the help of another group of drugs, which is called JAK therapy. So there is a 30% patient who is not responder. So in these situations, other things are coming up called JAK therapy. We are not going to talk about the DMRD, biologics. It is a big subject as such. What are the biologics available today? How it is coming to be and how is it? A basic point I have told you where it works. It is antagonistic to this thing. I introducing said it antagonistic. The antagonists also have a good and bad result as well. Good result that it further inflammatory process is curtailed down. Yes. Now limitations say it is a delayed in onset reaction, failure to tolerance to the patient sometimes. Side effects are there as I mentioned already. Injectable option many times, unlike biosimilars which can be oral also. So it can also absence of pan cytokine activity. That is pan cytokine activity may be, but certain biologics are effective to certain peptides only. So some biologics are only effective to interleukin 1, interleukin 6, like that. Yes, that is in details you're supposed to know which biology work where. You may not have a pen control. So if you are giving medicine also, you cannot ensure that patient will be a good responder to it because certain biologics are antagonistic to certain peptides only. Understood my point? So now need to target is a strategy now. Need to target excellent treatment response achieved by the agents which are nowadays added. The biologics are basically anti-peptides. It is understood. But as now, small molecule like JAK inhibitor, what is called Jonas kinase inhibitor, like tofacitinib, baricitinib, or other